Welcome to Consulting Chai. Today, we're again talking about hospital basics, and the topic we have today is Radiology and Imaging Department. I'll try to keep this very short. The content is actually very big, but in order to keep it short, I'll just cover the basics. Okay, so today we'll be covering about MRI, then the radiation equipments, and then USG, then critical alert, then turnaround time, then we'll talk about red peer, and then clinical radiological meeting. So here we go. So MRI uses high magnetic field and radio waves to create images. So MRI is very good to see tissue level images, and unlike X-ray, you're using RF shielding there. So for X-ray and radiation, what we do will cover in the next slide. So for MRI, it is very important that we safeguard the vicinity from any unwanted metals which can disturb the equipment. So it is very important that the staff stay very vigilant about these things, and the signages are very important for MRI. So for MRI, you can use the signages where you are saying no access for unauthorized persons. It's a strong magnetic field. It's always on, and there's no access for a person with unapproved implants, and no unapproved objects because there is a huge projectile risk. You can Google it, you can Google saying MRI accidents. You will be able to see there were many metallic objects which are stuck in MRI, which in order to remove that, we'll have to remove the whole helium, and to refill the helium, it costs lakhs of rupees, and a lot of headache, and several loss of your opportunity of patients. So it is very important that the staff always stays vigilant about these things. Now about the radiation equipments. Radiation equipments are like X-ray, CT, cath lab, C-arm. So the processes I'm saying needs to be followed in all these places. Also mammography. So infrastructure wise, you have to have a 10-inch wall, and then for the doors you have to put lead linings, basically the lead sheet, which should be at least 2 mm thick. And then you need to have a RSO who looks after the process and the safety training of all the staff which are working there. Then you need to put this signage which is shown here in the slide. This is as per the ARB. So on the left hand side, you have all the precautions written along with the type of equipment, model number, license. You have the inverted triangle, and then you have points written like X-ray examination is going on inside, do not enter, please wait for your turn, do not stay inside X-ray room, if required to assist the patient, insist for protective apron. And then you have the caution related to pregnant women. Okay, and then on the right hand side you have the license put, and this is for the signage. And another thing you need to take care of for these equipments are, you need to have your lead apron, get it checked at least once in a year. So that is as per the standard, but I generally say do it every 6 months at least. So I generally tell my hospitals to use CT image, because you can get a larger picture of the apron. You also need to asset code the apron so that you can have a reference of those apron in the report, which has to be signed by the radiologist. So when you go inside a X-ray, CT, cath lab, or C-arm, you need to have those reports of radiologist stating that these aprons there were no cracks found, and these are good to use. And you need to have the TLD badges every 3 months. You need to send it and get the reports and keep the reports in a file. And another important thing is ALARA. So ALARA stands for as low as reasonably achievable. So if you give more radiation, you will get more clear image, and if you high quality image, but because of the radiation, high radiation, it's harmful. So if you put low radiation, the image quality is bad. So that is why it has to be optimized. So there is a way to find the ALARA and stick to it and adjust the equipments accordingly. There are more points, like you have to have a quality assessment report where you have to see the radiations found in all in the vicinity of the imaging room. Okay. USG, ultrasonography. So for ultrasonography, one of the very important thing is, first you have to put this signage, the PCP and AT signage, where the year the act is properly mentioned along with the year, the fine, everything, penalty for the doctor, the family members, all these are written clearly, and it should be written at least in bilingual. Okay. And in USG you need to give proper privacy, so you must have a real curtain in case in the same room if you have multiple USGs. And preferably basically it should be away from the radiation equipment like X-ray, CT area. Critical alerts are like certain cases where you need to tell the consultant who has referred the patient. So those kind of alerts are basically which are asymptomatic, and it was only seen through the imaging procedure. So whenever those critical alerts are seen, it has to be informed to the consultant. So in order to do it properly, you first need to have a list of critical cases or scenarios defined, and it has to be signed by the radiologist. So for X-ray it will be different, for CT it will be different, for MRI it will be different, for USG it will be different. So first the list, which has to be approved by the radiologist. And the imaging department, they need to maintain a register for critical alert where they are writing about the patient name, the UHID, male, female, the date, the time of intimation, to whom it was intimated, and to whom, which department. So basically it should be first intimated to the radiology department should first try to intimate it to the consultant who has referred the patient. If the consultant is not available, if the department is not able to reach the consultant, then the consultant's team member should be informed. And if the consultant team member is not available, then the RMO who is looking after that ward should be informed. And if the RMO is not available, somehow he is not reachable, then the nursing station in charge should be informed about that. And similarly, the ward, in the ward they also need to maintain the critical alert reporting. So in the register they write about the name of the patient, the UHID, sex, and what they have found out, and at what time it was informed, and who informed it, and who has taken that information. It is important for both the radiology department and the inpatient department to write about the time and who has informed. Otherwise, they can be big fights. So, in order to safeguard yourself, you need to write all those details very diligently. Another important aspect of radiology department is the turnaround time. So the turnaround time, you have to define it, and then you have to track it. Okay. So turnaround time in radiology is basically the time from when the patient enters for procedure till the report generation. And the reason why we are doing this is to track it is to track it and then analyze it and then improve it. Okay, so in general, what as per my experience, USG, the turnaround time is about 30 minutes to 60 minutes, and because it is short, so there is no stat for that. And then you have the X-ray. For X-ray, it varies. So the routine procedures, it may take 2 to 4 hours, and then for urgent ones, it may take 1 hour. And then for CT, varies from 6 hours to 24 hours, and in urgent cases, it can be as short as 3 to 4 hours. For MRI, again 6 to 24 hours, and for urgent cases, 5 to 6 hours. Now, please take a note of this, that these durations that I'm writing here, it is as per my experience, and it varies tremendously as per from hospital to hospital, and also due to unavailability or availability of radiologists, and about the geographical location of that, and the working system, the work culture of the hospital. Okay, so all these factors changes this turnaround time a lot. Then for more quality improvement of the radiology department, you have this tool called RedPeer. So the requirement is that you need to have a internal or external peer reviews. So how do you do that? So if there are several radiologists in a hospital, then the HOD or the group of peers, there can be a group of peer who will be assessing other radiologists. Okay, and if there is just one radiologist, then it has to be an external peer review. Okay, so here what we are doing is we are exchanging the reports. So for the same image, there will be 2 or 3 reports for the same image, and then we use the RedPeer checklist. So for RedPeer checklist, I'm just telling you the main things. So you have to score the you have to compare the reports and score it accordingly. So when the 2 reports are concurring, then you score 1. You score 2, then 2 has 2 types. 2 is discrepancy in interpretation, which is not ordinarily expected to be made. So it's understandable that it might be missed by several radiologists. Okay, so for 2 you have A and B. A is unlikely to be clinically significant, and B is likely to be clinically significant. And similarly, in the third scenario, you score a 3. So 3 is basically discrepancy in interpretation, should be made most of the time. So it should not have been missed most of the time. So here you have again 2 types: unlikely to be clinically significant and likely to be clinically significant. So when you have more of three B's, there is you'll see the problem there. Okay, which should not be the case. So it is not a fault finding exercise, but it is to identify the where the problem is, where we can make the improvement. Then we have the clinico-radiological meeting. So meeting of the radiologists and the other consultants, specialists. That can be the gynecologist, medicine, general surgery, all sorts of consultants. So this meeting is very important, so that they sit and discuss about certain expectations or improvement that can be done from each side. So it has to be a predefined it has to be done in a predefined interval for correlating of imaging results should be done. MRI and CT can be taken. So they should take imaging results which did not meet the clinical expectation, and there were certain misinterpretations. So those things needs to be discussed, so that in future that can be avoided. And because it's a two-way discussion, so the radiologist can tell what they are what the consultants can do, so that their job is easier. And the consultants, they also need to tell the radiologist about what they are expecting more in the reports. So thank you for watching till the end. Please like and subscribe for more such contents, and keep supporting Consulting Chike. Thank you. See you again.